Hi, this is Barbara, and I'm going to talk about Menkes disease today. Menkes disease was first described in 1962 by Dr. John Menkes, a pediatric neurologist. He noted the phenotype of neurodegeneration, retarded growth, and peculiar white hair in 5 male infants in one family in two generations. And this was in the setting of a sex-linked recessive pattern. Then there was kind of a connection made to copper metabolism when similar hair changes and ataxia were observed in newborn sheep whose mothers had grazed in a copper-deficient area. Almost all cases of Menkes are male, with rare affected female cases in unique genetic instances such as Turner syndrome. So Menkes disease incidence in this rare copper transport disorder is about 1 in 140,000 to 1 in 300,000 births. About 1/3 of those are de novo mutations, so no family history of the disorder. It affects races and ethnicities equally. Menkes disease has many names, including copper transport disease, Menkes syndrome, kinky hair disease, steely hair disease. It's often detected about 2 to 3 months after birth. And Menkes disease is a fatal disorder with few children living past age 10, but most succumbing by age 3. Infants with Menkes disease are healthy at birth in appearance and have some subtle commonalities that are noted in infants that later will be diagnosed, and this is kind of noticed in hindsight. Often delivered by they have a preterm delivery. They can have a cephalohematoma with cesarean delivery. They often have hypoglycemia, hypothermia, and jaundice, all requiring treatment. Symptoms tend to present themselves about 2 to 3 months of age, and the infants have a loss of developmental milestones. They often lack visual tracking. They develop hypotonia, have a sagging facial appearance, and ptosis. They develop this really different kind of hair. It's sparse in quantity, hypopigmented, and twisted. It's kind of twisted on an axis, 180 degrees. And that is very distinctive for the disorder. They have failure to thrive, feeding difficulties, seizures that worsen in severity, over time. Through diagnostic further testing, that will reveal defects such as aneurysms, skeletal abnormalities that include fractures, osteoporosis, joint hypermobility. They can have urology issues such as bladder diverticula, dilated ureters, and they frequently have challenges regulating their body temperature. So the young infant presenting with new hypotonia, failure to thrive, and seizures, that cluster really raises a red flag for Menkes disease. They may or may not have the abnormal hair at that point, but these 3 symptoms are real concerning. Diagnostic testing can include serum concentration of copper and ceruloplasmin level. The ceruloplasmin is responsible for transport of copper from the liver to the organs. And so this and the serum copper level are going to be low in Menkes disease. This test is only valid after age 6 weeks because all infants are low prior to that. Right at birth, though, if you have an infant with a high suspicion due to family history, you can check a catecholase assay. You can have abnormal catecholamines in the Menkes affected infant, and that can be checked through plasma or CSF. So further testing, you're going to see the microscopic examination of the hair that you can see here. And then further testing will reveal some of the abnormalities with Menkes, like I said, with x-ray, show the bony abnormalities. A lot of the vascular abnormalities are going to be revealed with MRI, and also coronary vessels, with an echo. And pelvic ultrasound will show the diverticula. And then certainly monitoring for the seizures, you're going to see abnormalities with their EEG. So talking about the genetic mechanisms with Menkes, it's caused by a mutation on the ATP7A gene, which is located at X, so the X chromosome, Q, so the long arm, 21.1. The Mendelian inheritance number also has, a pound or hashtag symbol in front of it, indicating that another disorder shares the same locus. In this case, it's a milder, non-fatal disorder. The mutation causes occipital horn syndrome, which is similar to Menkes but lacking the neurologic symptoms. Menkes is an X-linked recessive inheritance type disorder. Over 150 mutations cause it. You can have insertions, you can have deletions, but they all result in a dysfunctional protein. And this protein is a vital copper transporter. So it is unable to transport copper from the Golgi apparatus to the systemic circulation, so to other cells in the body. Also impairs transport of copper across the placenta. So this deficiency starts in utero. So copper, will be absorbed into the intestinal enterocytes, but it won't go past there. It will not pass on to the systemic circulation. So copper is a cofactor in a number of critical enzymes, enzymatic processes in the body. So this is going to cause defects in bone, skin, hair, blood vessels, and the nervous system due to that deficiency. And a couple examples include cytochrome C oxidase. So this is going to cause, issues with the central nervous system that lead to degeneration of tissue. Lysyl oxidase, it's critical for collagen synthesis. So you're going to have connective tissue problems. So you're going to weaken blood vessels, like aneurysms is an example of that issue. Also, beta hydroxylase. This is vital for conversion of dopamine to norepinephrine. Also causes some hypothermia. This defect is utilized, in the catechol assay in identifying affected Menkes patients. So there's no current FDA-approved treatment for Menkes disease, and care is primarily based on symptom management. So of course, treatment for seizures, supportive care for feeding issues that might involve a feeding tube, correction of bladder diverticula, because of the bony abnormalities, that extends to the teeth. These kids have a lot of trouble with caries. Some investigational treatments. There are phase 3 clinical trials underway with supplementation of copper histamine, and this is administered subcutaneously, so of course to bypass, the gut. And there's been positive results with increased life expectancy, but this is only when it's initiated prior to the onset of symptoms. Then preclinical trials have been positive with high-dose recombinant adeno-associated virus serotype 9 ATP7A injected into the CSF in mice, and this has been done in tandem with the copper injections, and they have seen improved life expectancy in mice in these preclinical trials. So children with Menkes disease, sadly, they typically suffer a progressive neurodegeneration, and the cause of death is typically respiratory failure or pneumonia, and they typically succumb, the bulk of them between 7 months of age and 3.5 years, although there can be older cases, as I mentioned before. Additionally, there have been a few rare instances of mild Menkes cases that lack seizures and do not, have an early death. These are being studied, but they are distinct from occipital horn syndrome. Okay, some of the ethical, legal, and social implications. In cases of an identified, carrier, prenatal testing can be done and give the parents an option to decide about termination of the pregnancy, if they reside in a state or country in which that is legal. Menkes can also be detected by pre-implantation genetic diagnosis, to permit just transfer of healthy embryos. Carrier status testing also can be addressed, with siblings, but that's not going to be explored until they're 18 and after genetic counseling. Psychologists are vital in the care team with these cases, and they can assist parents and siblings with the emotional toll of, this really tragic disorder. The social worker can assist with economic concerns, of caring for such an ill, disabled child, requiring very intensive care. Also, they can guide families to apply for benefits from the Social Security Administration. Menkes disease does qualify for fast tracking of an application. Additionally, families can be guided towards clinical trials for appropriate treatment, by their provider. And here are my references, and I look forward to your comments and feedback. And thank you for listening to my presentation.